Good afternoon, and welcome to today's COVID-19 informational vaccine webinar. My name is Dr. Courtney Matisse, and I'm the Director of Health and Wellness at Alberta's Magnus College. Last week, President Biden and the Department of Education invited college communities around the country to sign up for the COVID-19 College Vaccine Challenge in an effort to get as many people vaccinated as possible. Since our fall reopening plans will be contingent on how many members of our community are fully vaccinated, this webinar is one aspect of our college's response to the community. So whether you're already vaccinated, thinking about becoming vaccinated, or are undecided, we hope that you find today's webinar informative and help answer questions that you have. Before we begin, we have just a few housekeeping items to review. First, everybody is muted and will remain muted throughout the presentation. If you have any questions, we welcome you to submit them via the Q&A function on the bottom right-hand corner of your screen. These questions will be collected throughout the webinar and asked to the panelists at the end of their presentation. Second, the purpose of this webinar is to discuss vaccines from a medical and scientific perspective. If you have any specific questions related to Alberta's Magnus's policies or the upcoming fall semester, we encourage you to go to the college's reopening webpage throughout the summer for the most up-to-date information. Please understand, many of our future policies are contingent on how many members of our community get vaccinated. That's why we're here today, to get the facts, to have myths dispelled, and most importantly, for you to get your vaccine-related questions answered. This webinar is also being recorded for your future reference if needed. We are beyond excited to welcome our panel of experts, Dr. James Hadler, Dr. Benjamin Tolchin, and Elizabeth Magenheimer. Each one brings to us decades of experience and expertise in the area of medicine. We will begin with presentations by both Dr. Hadler and Dr. Tolchin, but first let me share a little bit about them. Dr. Hadler is a physician epidemiologist trained in internal medicine, infectious disease, and preventative medicine. He's also a consulting epidemiologist to the Connecticut Emerging Infections Program at the Yale School of Public Health. And prior to this, he was the Connecticut State Epidemiologist for many years. I was in charge of all the state's infectious disease control programs. Dr. Tolchin is the director of the Center of Bioethics at Yale New Haven Health and assistant professor of neurology at the Yale School of Medicine. His research focuses on the impact of crisis standards of care and triage protocols on racial, ethnic, and socioeconomic health disparities. He's well recognized within the medical community and investigates the use of motivational interviewing, smartphone apps, and other novel behavioral and technological interventions to improve treatment adherence and outcomes with his patients. After both presentations are completed, the formal Q&A portion of this webinar will begin and will be facilitated by our very own Elizabeth Magenheimer. Elizabeth has worked as an APRN at Alberta's Magnus for over 40 years. She's also a family nurse practitioner, midwife, and co-directs the diabetes prevention program at Fairhaven Community Health Clinic. She's also taught clinical medicine at the Yale School of Nursing, as well as numerous other universities. Each member of our expert panel has graciously committed to being here today to help our community. So, without further ado, I'm going to turn things over to Dr. Jim Hadler, who will speak to us about the history of vaccines and their significance and wellness, about the health and wellness of our community. Dr. Hadler?
Okay, good afternoon. While we're waiting for my slides to come up, here they are. I'm going to be presenting a public health perspective related to vaccination against COVID-19. And next slide. Next slide, please. Yep, this is an outline of what I'm going to be presenting, which was Courtney already mentioned part of it. I'm going to be talking about herd immunity, variants, how vaccines work, vaccine safety monitoring, and what I think you should be worrying about now. Next slide. Okay, first I want to start with herd immunity. The term herd immunity originated from veterinary use, as you might suspect. Basically, when enough animals in a herd developed and survived an infectious disease, it ceased to circulate in the herd. When this concept was recognized, the whole idea of potentially slaughtering all the sick animals in a herd to try to save a herd kind of ended, and it was decided to depend on herd immunity to protect the herd in general. From a human perspective, I think a preferable term is community immunity. And the definition of community immunity is a form of indirect protection from infectious disease that can occur when a sufficient percentage of a population or a community has become immune, whether through vaccination or previous infection. Next slide. This slide illustrates some aspects of community immunity. Starting with the panel on the left, population or community with no vaccination, we start out with one infected individual in red on the left. That person has 5 contacts and ends up infecting 2 of them. Each of those 2 contacts, also shown in red, then has 5 contacts, and each of them infects 2 more. And you can see with no vaccination and no community immunity for a disease like COVID, you can quickly go from 1 case initially to 4 cases just 2 generations later. So taking the same community with 50% of them vaccinated with a very effective vaccine, again, the 1 case on the left has 5 contacts. Now 3 of those are protected from by being vaccinated, but 1 of the 2 remaining becomes infected. And the same thing happens in the next generation. Basically, we stopped the transmission from 1 person that we would have seen before, and the amount of transmission that the first generation of cases can produce is only 1 more. So we see that in 2 generations, even though the disease has continued, the total number of cases is much smaller. And this is what we get with community immunity. Next slide. So how has community immunity worked in the past? There have actually been a number of viral diseases that have at least been temporarily totally eliminated in the US by community immunity. This starts, the most prominent example is the 1918 to 1920 pandemic H1N1 influenza, which was basically, this virus circulated for 2 years and then disappeared after 2 years. And it was felt that the reason it disappeared, even though influenza itself didn't disappear, was community immunity. But that community immunity came at a terrible price of hundreds of thousands of deaths, especially to younger and middle-aged individuals. The next disease, just to mention, is smallpox, which was eliminated with vaccine. With more strategic vaccination, it didn't necessarily require total community immunity, but at a population level, but around each case of smallpox, vaccinating all their contacts and all their potential contacts, that little community was enough to stop smallpox when it was done very systematically. Measles and polio are the 2 more recent examples, and I think most of your memory, because their efforts at their elimination continue. But measles and polio both had high enough vaccination levels in the United States and in the Americas to have 0 cases occur for sustained periods of time. But what's happened is some other parts of the world haven't had that happen, and we keep getting measles reintroduced, and it sets off little chains of transmission, usually that are self-limited, but often provoke a response to make sure new susceptible people in our society, susceptible through immigration or through birth, are vaccinated. With polio, I think you're all familiar with efforts to eradicate polio around the world. Has turned out to be challenging, even though there's community immunity has been achieved in most countries and polio has been eliminated. There are a few countries where it hasn't, and because of war and other social disruptions, they've never quite achieved high enough vaccination rates. So in some countries, it continues to circulate, and every now and then it gets transmitted to another country that hasn't been able to sustain high levels of immunization in young children, and it will transmit there for a period of time. So the bottom line of this is that you need to maintain high levels of immunity to sustain elimination, which has been a challenge for measles and polio. Can we achieve full community immunity anywhere in the United States? Full meaning we can sort of eliminate it, transmission in a place for a period of time. And I think we can, certainly at the college, nursing home levels, maybe at the town level, maybe at a state level, without having it at the national level. But to get there, we first need to achieve and then maintain high levels of immunity. How much immunity do we need to have full immunity? That's a question. It was thought initially about 70% would be enough, but with the variants that have been emerging, and also questions about the duration of immunity from, especially from natural infection, it's felt that we really need to achieve closer to 90% to really stop circulation altogether in any given community, state, or country. So I think at this stage, given enough vaccine hesitancy, it's doubtful that we can achieve full community immunity at the national level. But again, I think we can at other levels. Next slide. So I want to turn to variants, COVID variants, and how concerned should we be? Well, variants basically arise in two ways. First, you can get imperfect copies. The virus enters a cell and starts reproducing itself, and produces millions of copies, and they're not all exact. Some of them have mutations in them. Another thing that can happen is you can get two variants in the same cell at the same time, and their genetic information can be exchanged. And you can produce a virus that has characteristics of each of those two variants. So the main concern about variants is that they tend to be they can be more transmissible. Sort of, you can imagine them being sticky. It's possible that you can inhale some virus particles and exhale them again without them ever sticking to a cell. But some of the variants tend to stick to the cells and then infect them much more readily than the first strains that we knew about with COVID-19. This is especially the examples I think you've heard most about are the British variants and the Indian variants. Some of the variants are also more able to infect those with past infection, or even possibly people who are vaccinated, not necessarily to cause severe disease and death, but to cause an infection that can be sustained in those individuals before their immunity kicks in. There's the Brazilian strain, the South African strain, and the Indian variants all fall into this category. What we're really worried about, though, is variants emerging that are totally able to bypass previous immunity. That hasn't happened yet, but it is possible. It happens regularly with influenza, not with the strains that we usually see, but the strains that we worry about for new pandemics. There's number soup following this of different strains of influenza that have emerged in different parts of the world and infected humans, but so far they haven't been very transmissible from human to human, and so they haven't yet been a major problem. But the bottom line is I think we should be very concerned about variants, and to minimize the potential for them to emerge, we need to achieve high levels of national community immunity to minimize their arising here. The fewer infections, the fewer chances a variant has to emerge, because the virus can't, if it's not multiplying, it can't produce variants. And we need to achieve high levels of population immunity worldwide to minimize their arising elsewhere. And we need to continue to monitor for new and different variants. Next slide. So this is going back to this community immunity illustration, taking a look at just the panel with no vaccination. For some of the variants, we start with the one red cell, and even though this slide isn't modified to reflect it, instead of that one person infecting two more, and each of those infecting two more, now they would be infecting four more, and that next one would be infecting four more, all with exactly the same level of exposure. And this is why when a variant comes in, even to a population that has a fair amount of immunity, like is happening in England right now, a new variant, in this case the Indian variant, is now becoming dominant in England. They're actually having an increase in cases despite having vaccination levels as high as we have. Next slide. So how do vaccines work? I want to mention in the whole issue of immune memory. Well, our basic immune memory system initially we respond to foreign invaders in the short run, but during the time we respond, we developed programmed memory cells to respond more quickly when we see the same thing again. Cells are programmed to recognize specific proteins on the surface of the invader, a virus or a bacteria. Two main cell types, B cells, which produce antibodies, T cells, which produce cell-mediated immunity. Vaccines take advantage of how we respond to real infection. If we provide specific proteins to make the immune system think there's a real infection, then we get programmed memory cells that make us respond much more quickly the next time around. And the key SARS-CoV-2 protein for immunity is the spike protein, about which you've all heard. Next slide. So how does the immune system get exposed to the COVID spike protein? There's two ways: natural infection and vaccination. With natural infection, the virus enters cells, takes over the cellular machinery, produces millions of copies of itself. These copies, some of this result in spike protein being expressed on the virus surface, of course, but also on the surface of the infected cells. Some are released into the bloodstream, and that's enough spike protein to stimulate the immune system to produce both kinds of memory cells. Next slide. With the approved vaccines in the United States, there's two very similar mechanisms as to how they work, and they basically work by mimicking infection. Messenger RNA is given via injection, taken in by cells. It instructs the cellular machinery to produce spike protein, which is then expressed on some cells and also released into the bloodstream, stimulating the immune system. This messenger RNA has a very short lifespan, several hours to days, after which it's gone and doesn't produce any more spike protein. This is the Moderna and Pfizer vaccines. The second way this can happen is we take another virus, in this case an adenovirus, that's unable to replicate, and we insert the gene to produce the COVID-19 spike protein. We give this via injection. This is taken in by cells. It carries the spike protein genetic code that causes the cell's cellular machinery to produce spike protein, and on with the same sequence of events. Once immunity develops, the cells with the genetic code are killed by the immune system and no longer produce spike protein. This is the Johnson & Johnson vaccine, the AstraZeneca vaccine, and Russian and Chinese vaccines that you may have read about in the paper. Next slide. So with that, I just want to turn to vaccine safety monitoring. There are three phases in vaccine development. The first two phases, during the first two phases, studies are conducted that test the safety, side effects, and to try to find the best dose of a new vaccine to produce just the right amount of antibody and immunity to just enough to program enough cells so that we have lasting immunity. These studies are characterized by having small numbers of volunteers in the range of 10 to 1,000. They usually last several months. Then in phase 3, once the right dose has been determined and safety within the context of a small number of people has been determined, much larger numbers of people are entered into clinical trials, 40 to 60,000 people divided into vaccinated and control groups. And the purpose of these trials is to look at the effectiveness and side effects in a much larger population. So there's careful monitoring and follow-up of everyone enrolled. This usually lasts for several years instead of months. It lasts several years more for the duration of immunity than for side effects. No vaccine, to my knowledge, has had side effects that first occur more than a few months after. And so when there were no serious side effects detected in the trials of the Pfizer, Moderna, and Johnson & Johnson vaccines, after at least a few months of trial, the emergency use authorization was issued. Next slide. So there's another component to vaccine safety monitoring, which you've also heard about. This is the post-licensing safety monitoring. So once a vaccine is licensed and in use, this system looks for side effects that are too rare to be caught during phase 3. There's systematic analysis of all reported possible side effects. So far, there have been 3 side effects of concern, again, that I'm sure you've all heard of. One is anaphylaxis, having an acute reaction right after getting the vaccine with hives and sometimes more serious symptoms. Blood clots, especially in younger women, and myocarditis or inflammation of the heart in younger age individuals, especially those less than 25 and especially males. The analysis of this data has resulted in the following. For anaphylaxis, the size of the problem was not very big, and it was determined the best thing to do was to watch vaccinees for up to 30 minutes after vaccination, and you could manage this particular complication perfectly well. With the blood clot issue here in the United States and in Europe, use of vaccines, AstraZeneca in Europe and here Johnson & Johnson, was temporarily paused until they got more information. That additional information determined that there is a causal relationship between vaccination in younger women and some of the clotting complications that they experienced, although very rarely in terms of like we're talking about 1 in 100,000. The resolution is to provide specific treatment guidance because these clots could be managed, and then to resume vaccination. And why resume vaccination if there's any possible serious side effect? Well, in this case, the benefit far outweighs the risk of clots and other complications from COVID infection. One shouldn't forget that COVID infection is often complicated by blood clots in all parts of the body, and of course many other complications. Finally, with myocarditis, this is still under study. There has been no pause as data as to causality and is still unclear, and the myocarditis appears to be very self-limited. However, it is important to point out that myocarditis following COVID infection is much, much higher, especially in younger people, than it is could possibly be based on what we've gotten from reports from getting the vaccine. So again, the risk-benefit here is the benefit is much greater than the risk in this situation. Next slide. So the main remaining safety concern from my perspective is, will there be rare side effects when vaccine gets authorized for less than 12-year-olds? We think that that's everything we know from other vaccines is that it's highly unlikely, but nonetheless, we have to keep an open mind. In the US, now more than 200 million doses have been administered to those 12 and older, and I think it's something close to 168 million different individuals. And in essence, this is the biggest post-licensing experience we've ever had. And I think we're highly unlikely to discover other side effects. So from that perspective, vaccines are looking ready for full licensing for adults because we understand the possible side effects, even if we don't still know whether we're going to need booster doses in the future. Next slide. So I want to briefly touch on a few possible misconceptions that I was asked to touch on. First of all, was the vaccine development rushed? It was certainly sped up. It went through phase 1 to 3 studies very quickly, largely because there was funding. Phase 3 studies started getting organized as phase 1 and 2 studies were being carried out. And so in essence, they sort of all started at the same time. The only thing that the speediness compromised was how long protection lasts and whether need a booster. It was not compromised from a safety perspective. It's gone through all the routine safety monitoring and scientific approval steps without political interference. With so many now having gotten it, we now know how safe it is to be given these vaccines in large numbers. A second conception, is there a chip embedded? I'm not exactly sure where this came from, but I think it may have arisen with terms like the use of RNA, messing with basically your genetic material. Well, there is no physical chip, although there are some people who have actually gone to the trouble of having x-rays and scans to try to find a chip, nor is there a genetic chip. The genome of the cell isn't affected by vaccines. We just give the cell messages to produce spike protein for a few days. Messenger RNA has a short lifespan, and the gene to produce spike protein in the J&J vaccine only temporarily works before being destroyed. Next slide. So what should you worry about? There's 2 levels. First, at the individual level, I think you should continue to be worried about getting COVID if you don't have any pre-existing immunity. And even then, you still want to be careful because you never know whether your immunity is going to be adequate or not. COVID disease has not changed. It's not totally predictable who will have serious infection and who will have long-term consequences. It's also likely that the same people who might have a rare, serious immune reaction to the vaccine would have the same reaction, only worse, with a much bigger stimulus of COVID infection. At the community level, including workplace, schools, and nursing homes, the lower the level of community immunity, the more potential for continued exposure of everyone, including those for whom vaccine is less effective. Having COVID continue to infect large numbers of people anywhere in the world increases the risk of a variant emerging, a variant that can evade immunity from vaccination or past infection and set us back. Final slide, please. There's the final few comments. Community immunity really starts with home, family, and friends. Be part of the community. Join in making sure we achieve the highest level of community immunity possible. Thank you for listening.
Thank you so much, Dr. Hadler, for that wonderful and informative presentation, which I'm sure has generated many questions from our audience. Before I turn things over to Dr. Ben Tolchin, I just wanted to remind everyone that we encourage you to utilize the Q&A function on the bottom right-hand part of your screen. All questions will be collected and asked to our panelists at the end of their presentation. So now I'll turn things over to Dr. Tolchin.
Thanks so much, and thank you, Jim, for covering that really important material. I want to just build on a few of the things that Jim said with a sort of a clinical perspective on vaccination. To begin with, Jim spoke a lot about herd or community immunity and the possibility of achieving it at a local level, if not at a national level. And we're in Connecticut, we're actually doing quite well in terms of vaccination. So over 50% of the Connecticut population has been fully vaccinated, and over 70% of the Connecticut population has received at least one dose of the COVID vaccines, which compares quite favorably to the national level. And so as we're thinking about achieving herd or community immunity in our state and in our region, we're actually well on our way towards that goal and quite ahead of the national level, which is going to be very important in terms of preventing illness, not only among vaccinated individuals, but among those individuals who either cannot receive the vaccine, choose not to receive the vaccine, or for reasons that we'll talk about, may not benefit from the vaccine. As Jim mentioned, while the COVID-19 vaccines were developed and tested very quickly, there actually is a long history behind these vaccines. So the mRNA vaccines, the Pfizer and the Moderna vaccines, which are the newer type of vaccine, actually have a 15-year history of research and development. So the mRNA vaccine technology has been under research for the last 15 years. And over the last decade, different types of mRNA vaccines have been developed, including influenza vaccines, Zika vaccines, and actually anti-cancer vaccines using this mRNA technology. The COVID-19 vaccines, the Pfizer and the Moderna, are the first to actually be utilized in humans under this emergency use authorization. And the hope is that starting in September, these vaccines will be receiving full FDA approval. This is a very prolonged process, and the hope is that process will be completed in September of this year. But the important point here is that the vaccines have a long history of research and development behind them. They have also now been used for over a year. So the first humans to receive the COVID-19 vaccines received them in March of 2020. So it's now been about 14 months since these folks were first vaccinated. And as Jim mentioned, there has been an enormous post-marketing monitoring process monitoring everybody who's been receiving these vaccines. That now includes more than 170 million Americans who have received these vaccines, the first of whom were getting the vaccines on a trial basis over a year ago. So we do have an enormous amount of data about both the efficacy of these vaccines and also their safety profiles, which I'll talk about, which Jim has already touched on. So in terms of the formal trials, as Jim alluded to, the studies involved tens of thousands of people, 43,000 for the Pfizer randomized trial, 30,000 for the Moderna randomized trial, and almost 44,000 for the Johnson & Johnson randomized trial. So in total, over 100,000 people were randomized to receive these vaccines versus a placebo, and the efficacy and safety profiles were studied. The Pfizer and the Moderna vaccines are 94 to 95% effective in preventing symptomatic COVID-19. The Johnson & Johnson vaccine is 72% effective at preventing moderate to severe COVID-19. But what's really important is that all three vaccines are nearly 100% effective in preventing the most severe forms of COVID-19, including fatal cases of COVID-19. They're not 100% effective. There have been cases of infection and even death here in Connecticut and nationally. Those cases tend to happen among folks who are immunocompromised in one way or another, either because of an illness they have, for example, a cancer that leaves them immunocompromised, like chronic leukemia, for example, or because of a medication they're taking that suppresses their immune system. For example, an immunosuppressant that suppresses their immune cells, their B cells. But for patients who have an intact immune system, the protection is nearly complete, nearly 100% effective in preventing fatal cases of COVID-19 with all three of the vaccines. Importantly, these trials involved folks with different medical comorbidities. So the trials involved both healthy individuals, but also folks who are suffering from long-term medical illnesses, including diabetes, hypertension, but also more serious illnesses like liver disease, severe lung diseases and heart diseases, and infectious diseases like HIV and AIDS. So we have a great deal of information about the safety and efficacy of these vaccines, not just in the general healthy population, but also among folks with significant long-term illnesses. And the important thing is that they are safe, and with the exception of folks who are immunosuppressed or immunocompromised, they are very effective. Importantly, also, these trials involved members of different racial and ethnic groups throughout the U.S. population. So there were significant numbers of Black, Asian, Native American and Pacific Islander, Hispanic individuals enrolled in these trials. So we have very good evidence about the safety and efficacy of all three of these vaccines in different racial and ethnic groups within the U.S. population. So some important facts that I really want to focus on today. So number one, COVID-19 vaccines cannot give the recipient the virus. So none of the three vaccines contain the COVID-19 virus. As Jim alluded to, the Moderna and the Pfizer vaccine contain mRNA that train one's cells to produce a specific protein, the spike protein, but no other component of the virus. And similarly, the Johnson & Johnson vaccine contains an adenovirus, which has been disabled so that it can't reproduce in your body, but it contains a gene for the spike protein, but no other part of the COVID-19 virus. And so it is impossible to become infected with COVID-19 as a result of receiving any of the three vaccines. Fact number two, the rapid development of the vaccines does not mean they're not safe. As Jim discussed and as I touched on, The history of these vaccines goes back for over a decade in the case of the mRNA vaccines, and for many decades in the case of the adenovirus vaccine, the Johnson & Johnson vaccine. And we now have not only randomized trials that were done with the COVID-19 vaccines involving tens of thousands of people, but we have post-marketing data from over 170 million Americans who received these vaccines. This is the largest post-marketing data collection that's ever been undertaken in the history of the world. So we really have a lot of information about the safety of these vaccines. Fact number 3, the COVID-19 vaccines do provide protection against multiple strains of COVID-19. As Jim alluded to, there are multiple strains of the virus. The most common strain in our region, in Connecticut and New England, is the B117 variant, which originally developed in the United Kingdom. And the vaccines are effective against the B117 variant. There are other variants that are currently emerging and that the vaccines are currently being tested against. We don't have data about all variants, but we do know that the vaccines are effective against more than one variant, including the most common variant in our region. Fact number 4, the COVID-19 vaccines do not change the recipient's DNA at all. The mRNA vaccines never involve any DNA at all, and only involve messenger RNA, which then results in the creation of proteins, but there's no impact at all on DNA. There's no involvement of DNA. And the Johnson & Johnson vaccine, with the adenovirus, it doesn't affect the patient, the recipient's DNA. The adenovirus does have the gene to produce the spike protein, but once the immune system is trained, it attacks the cells that have been infected with that adenovirus and destroys those cells, and the recipient's DNA is not affected. Fact number 5, the COVID-19 vaccines have not been linked to infertility or miscarriage. So large studies have now been done in pregnant and breastfeeding women, and there's been no evidence of any injury to a fetus or the newborn baby or to breastfeeding babies in these trials of the vaccines among pregnant and breastfeeding women. Fact number 6, we know exactly what is in the COVID-19 vaccines. I'll talk a little bit about the ingredients of the vaccines, but I think what's important to emphasize, number 1, these vaccines are, the ingredients are publicly available. You can Google the Pfizer vaccine ingredients and see the ingredients for yourself online, and same for the other vaccines. And number 2, there are no cellular materials. So one myth that's been discussed is the idea that there are fetal cells or stem cells in the vaccines, and that is not correct. There are no cellular materials in any of the 3 vaccines that are used in the United States. I'm going to skip over the discussion of how mRNA vaccines work. If people are interested, I can come back to this. And I'm going to skip over the discussion of how the viral vector vaccines work. I think Jim really already touched on this, but we can address this in the question and answer period if people are interested. I just want to review the 3 types of vaccine that are available. There's the Pfizer and Moderna, which are both mRNA vaccines, and these vaccines are 94 to 95% effective. They both require 2 shots. In the case of the Pfizer vaccine, it's 2 shots 3 weeks apart. In the case of the Moderna vaccine, it's 2 shots 4 weeks apart. And that is different from the Johnson & Johnson vaccine, which again, that's the adenovirus vector. That only requires 1 shot. The Johnson & Johnson vaccine does appear to be slightly less effective in preventing moderate to severe COVID, but all 3 of these vaccines are nearly 100% in preventing the most severe and fatal cases of COVID-19. We currently are still determining whether booster shots will be needed on an annual or on an every other year basis. My personal suspicion is that they probably will be, but that is still a question that's being researched. We can talk about that in the question and answer period if people are interested. In terms of the ingredients, I just want to reiterate, again, there are no cellular components, there are no fetal cells, no stem cells, there are no cells in any of the three vaccines. And the ingredients are publicly accessible if you're interested in looking this up online. In terms of the side effects, so this is a really important issue. So the most common side effects are redness and swelling at the injection site, a generalized weakness and fatigue, low-grade fevers, a generalized muscle ache or myalgia, and headaches. And these symptoms, these side effects are fairly common. They are particularly common after the second shot of the mRNA vaccines, the Pfizer and the Moderna, but they do also occur with the first shot of those vaccines to a lesser extent, and also to a lesser extent with the single shot of the Johnson & Johnson vaccine. I had the Pfizer vaccine myself, and I definitely had all of those symptoms. The important thing to know about them is that they almost always resolve within 36 to 48 hours of the injection. So, if it's possible to schedule your injection, particularly your second injection, when you're going to have a day off from work or school the next day, that's really ideal. I did go to work the day after my second Pfizer injection, and it was unpleasant, but, as I said, it resolved within 36 hours. More severe reactions are possible, and this gets into the question of who should exercise caution in getting the vaccine. So the most common serious side effect, and Jim alluded to this, is anaphylactic reaction. And the risk factor for that is a history of severe allergic or anaphylactic reactions to other things, to other medications or other foods. And what's recommended is for those who do have that history that they receive the vaccine, but they are monitored for 30 minutes after receiving the vaccine. And if they do have that anaphylactic reaction, it can be effectively treated with epinephrine and steroids. And I have, working in a COVID vaccine clinic, I have seen one person have this reaction, and they were fine. They did go to the emergency room. They got an EpiPen, they got steroids, and they went home later that evening. Other serious reactions that Jim alluded to are the blood clots in the head, what are formerly known as venous sinus thrombosis. It means a blood clot in the veins in your head, and that is a very rare adverse effect. That's thought to occur in about 1 in 100,000 individuals, and that's specifically with the Johnson & Johnson vaccine, and specifically in younger women receiving the Johnson & Johnson vaccine. And I think what's important there is to balance that risk, which is an important risk and important to know about, and important for doctors to be familiar with, and important for patients receiving the vaccine to be familiar with. But to balance that risk with the risks of the COVID-19 virus itself, which, as Jim alluded to, is, the risks are very severe, and particularly for older folks and folks with comorbidities, include significant risks of critical illness and death. But even for younger folks who are at lower risk of critical illness, who are at lower risk of death, the risk of long-term side effects with the virus are very high. A recent study of 55,000 active duty military personnel in the US military who had gotten the COVID virus found that although overwhelmingly these folks, being young, healthy people, did all right in the short term, a full 25% of them, 1 in 4, had long-term side effects lasting at least 6 months. And those side effects were most commonly respiratory, cardiac, and neurologic side effects lasting at least 6 months. So the long-term side effects of the COVID-19 virus are severe and common as compared to the potential side effects of the vaccine, which are overwhelmingly mild. And for those severe side effects, they are extremely rare, particularly compared to the side effects of the COVID-19 virus. The last thing I want to touch on before I'll hand things over for questions is the question about wearing a mask. So in the state of Connecticut and also nationally, the CDC and the Connecticut government both have recommended that vaccinated individuals no longer need to wear, are no longer required or recommended to wear masks outside, or in most cases inside, the exceptions being in healthcare facilities, in nursing homes, in public transportation, in correctional facilities, and in schools. Of note, this recommendation is not to suggest that people who've received the vaccine cannot wear masks. It's not simply that they're not required to, in most cases, being outside or being inside. I'm happy to discuss that in greater detail in the question and answer period. And with that, I will stop my presentation. And if you have any questions, I'm happy to be emailed and discuss further by email. Thanks so much.
Wonderful. Thank you so much, Dr. Tolchin, for sharing your expertise with us. And to both you and Dr. Hadler for being willing to answer questions from our community. I see some questions have already been submitted, and I wanted to encourage everyone to continue asking your questions throughout this next segment so we can have all of your questions answered by our panel experts. So we will now begin the Q&A portion of this event, and I will hand things over to Elizabeth.
Thanks so much, Courtney and Jim and Ben. We can't thank you enough. I also want to mention thanks to Albertus, having watched this, their experience and their response to this year, this novel year. You've worked really hard to keep everyone informed, up to date, safe, and tested. It's been a long year for all of us for so many different reasons, and the Student Services at Albertus is very aware that the whole community, each one in the community, has had a different effect from the COVID pandemic, and it continues to have, the pandemic continue to have an effect on our lives and all of our communities. We have some questions that have already been given to us. Going through the presentations, Jim and Ben, you really touched on the issues that were already identified by folks, but I think some of them you'll even want to emphasize more. The first question, I think I'll send to Jim, the first couple of questions. Jim, they are, one, I had the COVID, so I have antibodies. Why do I need the vaccine? The second related to that is, will I test positive for COVID if I've had the vaccine?
Okay, thanks, Elizabeth, for the questions. The first is, if you've already had COVID infection, you certainly have acquired a degree of immunity. That's true for most viral infections. One of the things with coronaviruses that we've been concerned about is that coronaviruses historically have not produced long-lasting protection, as long-lasting as, say, measles infection. However, it's what we think that you should do is that you should get vaccinated, and ideally get vaccinated maybe 3 months later would be a reasonable time period. We have seen quite a few people, actually I think Ben has seen at Yale New Haven Hospital as an example, a number of people who had an initial infection last spring and 3 months, 4 months, 6 months later developed a second infection that in some cases was more serious than the first one. And in getting a booster dose, both addresses the issue of how long coronavirus immunity might last, and the fact that we're observing infections can occur after second infections can occur. So I would strongly recommend that you, if you had previous documented infection, that you get vaccinated eventually, and ideally a 3-month interval is a very reasonable interval to consider starting to get reinfected at, or starting to get vaccinated at. As to having a positive test, there's 2 kinds of tests. One is the one that detects whether you actually have virus particles in you. That's the PCR test or antigen test. And the other is whether you have antibodies. So it's the PCR test or antigen test shouldn't be positive. However, the antibody test ideally would be positive. But antibody tests are not perfect. They're not as sensitive as we would like them to be, and sometimes they can be falsely positive. So I wouldn't, if you decide to get tested for antibodies after having had infection or to see if you've had infection, you can't totally rely on the results.
Thanks, Jim. Ben, did you want to say something about that also?
I mean, I would just encourage people who have been infected to strongly consider getting vaccinated. There is a 3-month waiting period from the time of your infection to when you can get vaccinated, but after that period, I'd strongly encourage it. You know, there are studies about the duration of antibody maintenance in people who've gotten infected, and it does appear that many people do maintain antibodies for prolonged periods, up to 8 months. But the fact is, we do see in the hospital, we see people getting reinfected after the initial infection. And so once that 3-month window where you're not allowed to get vaccinated passes, I would strongly recommend that folks do get vaccinated after that period.
And again, going back to the vaccine and the variants, can you just reiterate, Ben, how the vaccine, or if the vaccine will protect me in any way against the variants, if they're so different?
Right. So there are a number of different variants at this point. The most common variant in Connecticut and in New England is B.1.1.7, which originated in the United Kingdom, and that has been extensively studied. And the vaccines, all 3 of the vaccines, are effective against the B.1.1.7 variant, we believe. There are other newer variants. The one that arising in India that arose in India that Jim alluded to, that's now in the United Kingdom, and that probably will be coming here in significant numbers. And the fact is, we don't know as much about the vaccine's efficacy in some of these newer variants. We're currently studying them, but we do know that in addition to the sort of original strain of COVID-19, many variants are affected by the vaccine, including the one that is most common here in Connecticut, which is the B.1.1.7 variant.
Great, thanks. You touched on the fertility question, and I think that is front and center in everyone's minds, and the investigations have really risen to the occasion of looking for issues on fertility and the impact on fertility, and the answer has been there is no impact. Do you have a preferred vaccine that you would get? Do you find at any point that one should say, I only want this vaccine? Jim, if you want to give us an idea.
Yeah. No, thanks. I would say that certainly, all the vaccines, all 3 vaccines licensed in the United States are very effective in preventing severe disease. That's important to keep in mind, and potentially keeping you out of the hospital and keeping you from having severe lung and other consequences. Is there one that's, they each have their advantages. It's clear that Pfizer and Moderna vaccines in the trials had a higher level of effectiveness against mild disease, at least disease severe enough to take, mild but severe enough to take you to a doctor to get diagnosed, compared to the Johnson & Johnson vaccine. But despite those differences, the Johnson & Johnson vaccine has the ease of being able to be stored and used anywhere. At this stage, where we now have enough vaccine for everybody, and we have clinics for everybody, I would say if I had to choose, now that it's not sort of urgent anymore, I would probably choose the Moderna or Pfizer vaccine initially. But if we need a booster, I would be very happy to get a booster with the Johnson & Johnson vaccine. Or if I got the Johnson & Johnson vaccine and we need a booster, to potentially get a booster with one of the other vaccines. Those are all things still to be determined, of course. But there's the possibility of having whichever vaccine you want. And so that's where we are now. That was very different in April when the Johnson & Johnson vaccine came out and we had very limited supplies of other things. And the Johnson vaccine could be stored in pharmacies, it could be stored in nursing homes, it could be stored anywhere and administered in the home, and we didn't have to worry about storage issues.
Thanks. Ben, Albertus has a large international community, and certainly the United States, with travel. What about the vaccines from other countries? The students will be coming back to the Albertus campus having had vaccines from other countries. How should we feel about that?
Yeah, that's a good question. So I would very strongly prefer one of the 3 U.S. vaccines over either the Russian or the Chinese vaccines. I have more confidence in the trials and the safety monitoring that have been done with the 3 U.S. vaccines. AstraZeneca, I think, is comparable to the Johnson & Johnson vaccine. There are elevated, there has been cases of this venous sinus thrombosis, this blood clot that occurs in the veins of the head with both the AstraZeneca and the Johnson & Johnson vaccine. And probably the efficacy of both the AstraZeneca and the Johnson & Johnson vaccine is a little bit lower than the Pfizer and the Moderna. So I would generally think of the AstraZeneca as a lot like the Johnson & Johnson vaccine. As you know, though, the AstraZeneca has not been approved in the United States, and there has been some controversy about the data that AstraZeneca produced. So, Jim said, he'd be comfortable with any of the 3 U.S. vaccines, and I totally agree with that. I would probably prefer any of the 3 U.S. vaccines over the AstraZeneca, and I would definitely prefer any of the 3 U.S. vaccines over the Russian or Chinese vaccines.
And would you, following from that, will there be a recommendation that those folks receive the U.S. vaccines?
Good question. I'm not aware of
those who are.
Yeah, right. The people who already received the Russian or Chinese or AstraZeneca vaccine, must they also receive the U.S. vaccine? I'm not aware of any such recommendation. I don't know that there's formal guidance on that from the CDC. I would defer to Jim. Do you know?
Yeah, I don't think at this stage there is formal guidance. And I think, there was actually a very good article in the New York Times a couple of days ago about dilemmas that colleges are having, or anybody basically is having, in terms of accepting, if they're requiring vaccination, will vaccination with vaccines not approved in the United States be acceptable? And different places are handling it different ways. In terms of colleges, what I would personally recommend, and we'll have to see what CDC says, is that I would assume that those vaccines have been effective. They may not be as effective as the U.S. vaccine, and that if someone doesn't want to get another dose of vaccine, that they just wear a mask and get tested periodically before and go from there. Similar to someone coming in who hasn't been vaccinated. The idea is you want to keep them from potentially being able to spread it and also to protect themselves. So you ask them to wear a mask, you test them for a while, and if there's no circulation on campus, you can potentially decide later to either they get vaccinated if they want to, or or you can decide that things are safe enough that they can go without masks as well. So it's going to be an interesting time coming up. And this is coming up at the same time we have variants circulating. As Ben said, the B.1.1.7, the British variant, is the one that's been the dominant one in the U.S. But the Indian 617 variant is actually now makes up 7% of the U.S. cases, and it's in most states. And so I wouldn't be at all surprised if it bit by bit replaces the B.1.1.7, and we'll just have to see how that behaves here with our level of vaccination and immunity and avoidance to the extent that individuals are trying to avoid potential exposure, how that interacts. And that could also change recommendations in the future, recommendations around testing, around mask wearing, and possibly getting another dose of vaccine, which would totally change things. Personally, I would say, though, that I would consider, if I decided to revaccinate any of those people, I would personally only go for a single dose booster. I wouldn't go for a full series, but that's something to be determined. There isn't any science on that yet. So and you ask 10 people and you'll get 10 slightly different answers, but they'll all be erring on the side of sort of safety both ways, not overdosing people with vaccines on one hand and judiciously giving them boosters as it may be appropriate.
I'm going to go back to one thought that everyone has, and certainly in a healthy college community where we've been testing and testing and testing twice a week, 3 times a week. People are positive, they have no idea. People are young and healthy. So the experience of a vast majority has been that this thing has been an inconvenience and hardly a serious disease entity. And I think I have 2 questions from that. Based on that is, remind me why I should get the vaccine again. I don't know anything other than a nuisance. And the second is, why should I get it now? Ben, you want to start?
Sure, yeah. So again, I would really highlight this recent work coming out of the United States military. This is similar to a college cohort, right? So they have young, active duty military folks. These are young, healthy people, and by and large, they with COVID infection, they were able to stay out of the hospital. They were, by and large, they did not die, which is great, but fully a quarter of them had these long-term side effects, and we're seeing these in our clinics increasingly. These cases of sort of a general cognitive clouding. I can't think as well as I used to be able to. I can't remember things as well as I used to be able to. I'm tired all the time. I'm short of breath all the time. Some folks are describing this as long COVID or COVID long haulers, and fully a quarter of the active duty military folks who were infected with COVID-19 or known to be infected with COVID-19 had these kinds of symptoms lasting at least 6 months after their infection. So this is a really serious problem for young, healthy people, and I think is a really important reason to get vaccinated as soon as possible. In terms of why get vaccinated now, as Jim alluded to, we're getting progressive waves of new variants, and for example, this Indian variant is known to be more infectious and likely more dangerous than prior strains of the virus. And that's common, that the more infectious variants are pushing out older, less infectious strains. And so I think the sooner you can get vaccinated, the better. And if not to prevent severe acute illness, which is what we really worry about with older folks and folks with many medical problems, in the younger, healthier folks, we're worried about these wild cases followed by long-term symptoms. And I think that's really a very important reason to get vaccinated. One other thing I will say is you're not just protecting yourself, you're protecting everybody around you. So the vaccines are definitely effective in preventing asymptomatic transmission. So, a significant problem has been people who get infected. They're not aware they're infected, but then they spread the infection to others. And the vaccines are also effective in preventing that kind of asymptomatic transmission. So those are the reasons to get vaccinated as soon as possible.
Right. And I would just like to reiterate. Yeah, I would just like to reiterate that from my perspective, now is a perfect time. You can say incidence is going down. It seems like fewer people are wearing masks. Well, the mask recommendations for outdoors, of course, have been largely lifted. I'm free. Why should I get vaccinated? Because everything looks rosy. But that's, has been alluded to, things will not remain rosy indefinitely, number one. Number two is vaccine availability is at a peak right now. Number three is you really don't want to get infected and put it off until big problems arise, because if big problems start arising in the United States again, there's going to be issues around boosters. There may be issues around the vaccine supply and availability of vaccine. And now is the perfect time. I wouldn't wait. I would do it now.
Jim, continuing on there and talking about that now is the time we have the vaccines. If I have been vaccinated and we are going to give boosters, should I get the same vaccination that I got before, the same brand? And the second is, should I, when I get the same brand, should I worry about whether or not there's enough or there's not enough of the vaccine?
No.
How is the supply?
Yeah, well, those are good questions, but they're speculative questions at this stage. Of course, we don't know if we need a booster, why we're going to need it. Are we going to need it with exactly the same vaccine we got the first time, or are we going to need with a vaccine made with a variant strain so that it covers a variant that seems to have escaped our immunity? There's some questions there, and we don't know which manufacturer is going to come up with a booster vaccine that's different than the vaccine, the three versions, the Johnson and the current versions of each of the three vaccines that we've been talking about. So there's a lot that we can't totally predict. I can say, however, that most of the speculation from infectious disease experts, and actually studies now that are being done in England and Spain at least, and beginning to be done in the United States, are showing that if you mix and match vaccines, so you get one dose of, this has mostly been done in Europe with AstraZeneca, and then you get another dose with Pfizer, what happens? It turns out your immunity is great. You have, interestingly enough, you tend to have more side effects, more of the immediate side effects that have been discussed. What can you expect if you get vaccinated? Can you expect to have a sore arm? Can you expect to have a fever? Can you expect to be feeling lousy for a day or two? That's more frequent when you mix the manufacturer vaccines. Either way, you get Pfizer first, AstraZeneca second, AstraZeneca first, Pfizer second. But the immunity produced seems to be very, very good, at least as measured in the laboratory. We also have people in the US who are working abroad and come back home. They've had one dose of AstraZeneca. What should they get? So we're getting trials now because we don't have AstraZeneca to give them their second dose with. So these same kind of studies are being done in England and Spain, are happening now. But I think in the long run, what it looks like we're going to find out is it won't make that much difference. You won't have to get the exact same one. A booster from the same manufacturer, a booster will likely be a single dose and not two doses, although I can't say that for sure. If it's a 2-dose booster, then ideally you'd probably want to get it from the same manufacturer, though you wouldn't have to, just because fewer immediate side effects with the second dose, at least we're seeing from the mix and match type thing. So that's my speculative response at the moment.
Okay, and so Ben, the final question, and it's our questions are always about ourselves, and I certainly understand that. Is so I'm 80 years old and I've been fully vaccinated, and I want to go to New York and travel on the subway. I was vaccinated in February. Can I, doctor?
Right. So I mean, I think, it's important to think about the risks involved, and to think about sort of your attitude towards risk. If you want to absolutely minimize your risk, just being on the subway, even vaccinated, even with a mask, is some risk. I think it is a reasonable risk to take. I probably would advise an 80-year-old person who's been vaccinated to still wear a mask on public transportation, particularly a subway, which has very limited ventilation. But in my mind, it's a reasonable risk, particularly if this is like, to go visit your family that you haven't seen for a year because you've been in isolation while waiting for the vaccine. I think, I think that's a very reasonable risk-benefit calculation to make. But I don't think that just because you're vaccinated, you should just stop thinking about risk. I think that, there are, as Jim alluded to, there are still variants. We don't know how effective the vaccines will be against some of the variants. So going into a very enclosed environment like the New York subway, there is some non-trivial risk there, and I would just be aware of that and take that into consideration when you're weighing it against the benefits of perhaps seeing your relatives after a year of isolation.
Yes, and
I can't thank. Go on, Jim.
No, I was going to say, well, I'm a healthy, as far as I know, 75-year-old who's been vaccinated, and I'm actually in New York right now. I decided, visiting relatives, I decided not to take Metro North, not to take the subway, even though for many years I worked in New York City and took them every day, or not every day, but the days that I came to New York City. And I would if it was necessary, and I didn't have a car, I would take Metro North, I would take the subway, but I would wear a mask, and I would try to make sure I distanced from anyone who wasn't wearing a mask. But I'm not ready to do that on a routine basis yet.
Okay. Well, hopefully in closing one, we can't thank you enough. We hope we've answered everyone's questions, but we want to make it clear that you can send questions to the health clinic at albertus.edu. And in addition to that, this has been recorded and will be available on our webpage. We thank you, Jim and Ben, for your scientific knowledge. We also acknowledge that risk is a personal thing, so we all make decisions about what risks we are willing to take. And we want to thank all the participants for having the questions and wanting them to be answered in an intelligent way. Be well and be safe. Thanks a million.